Our next speaker is Professor Deborah Goldstein. She'll be giving the Uveitis Update lecture. Professor Goldstein received her medical degree from McGill University in Montreal. After her ophthalmology residency, she did fellowships in uveitis and ocular immunology at McGill, and then followed by a second fellowship at the University of Illinois. She has published widely, more than 250 papers, and is a sought-after international speaker. Professor Goldstein has conducted many investigator-initiated trials as well as multi-centre research projects. She's also been the recipient of numerous awards and honours from the AAO for both her scientific contributions and excellence in teaching. In 2021, she became an ARVO Silver Fellow. She is currently the Magna Stat Professor of Ophthalmology and the Director of the Uveitis Service at the Department of Ophthalmology at Northwestern University's Feinberg School of Medicine. It's my pleasure to welcome her with us today, and the title of her talk is Biologics Today and the Road Ahead. Thank you.
Thank you. Thank you so much for that introduction, and it is wonderful to be here. This is my first in-person traveling lecture for 2.5 years, and I am really excited to be here. Thank you. In terms of my disclosures, I've served as a consultant. We're a small group in uveitis, so we've all been consultants for everybody. The only relevant one here is that I was involved in the initial trials that resulted in approval of Humira. So my talk is about biologics, and the question is, what do we mean by biologics? So we all think of the drugs that we know. These are the small molecule drugs, but biologics are made in a different way. They're all made in a living system. So they're made in a microorganism or a plant cell or an animal cell. So it's a very different way of making drugs. These drugs are a lot larger than the small molecule drugs. And this little cartoon here, and I don't know how to use a pointer. Let's see, this little cartoon is supposed to show you the size of a small molecule drug versus these giant monoclonal antibodies. So we can't give these drugs orally yet, although there is research being done underway currently to try to see how we can give these drugs orally. But for now, they are too large to cross the gut, and they are too sensitive to the gut pH and digestive enzymes. So there are a lot of biologics that are in use and those that are in development, and I'm going to talk basically about the TNF inhibitors and IL-6 receptor antibodies. So in terms of tumor necrosis factor inhibitors, we have infliximab, adalimumab. I've put etanercept in parentheses because it is pretty useless for the treatment of uveitis. Golimumab and certolizumab, and I won't be talking about rituximab or abatacept just in terms of time, and then I'm going to spend some time talking about tocilizumab, an IL-6 receptor monoclonal antibody. So I live in the United States, if you couldn't tell by my accent, and all of these drugs are used off-label, with the exception of adalimumab, which is approved for the treatment of non-infectious intermediate posterior and panuveitis. So we have no drugs that are used on-label for anterior uveitis or scleritis. And I understand that in Australia you have the same thing, that Humira has been approved, although PBS doesn't pay for it, so it's not that helpful anyways. So basically what we end up doing is scrounging around, begging and pleading and playing with data to try to get our patients covered. So when do we use biologics? These are rarely used as first line, but there are some exceptions that I'll talk about. So we tend to use this as second line in patients who failed conventional immunosuppression, so patients who failed antimetabolites like methotrexate or mycophenolate. We do sometimes use these as first line, though, in patients with severe sight-threatening disease, so necrotizing scleritis. I'll try to get it approved very early for patients with Behçet's retinal vasculitis and serpiginous choroiditis. So I'm going to talk first about infliximab. This was the first drug that we had available. This is a chimera. It is 90% human and 10% murine. And this is important in terms of development of autoantibodies against the drug. So this was first approved for rheumatologic conditions and has still not been approved for uveitis. The standard dosage of this drug for rheumatologic conditions is about 3 to 5 milligrams per kilogram IV every 8 weeks, and we have found over the years that this is pretty useless for most ophthalmologic conditions. We tend to use about 10 milligrams per kilogram every 4 weeks, which makes insurance coverage even harder. In pediatric cases with severe uveitis, I've used up to 20 milligrams per kilogram every 4 weeks. And we do use antimetabolites in most patients concurrently to try to prevent the development of antibodies. So there's a lot of data, which I won't go over, for infliximab, and its efficacy in many forms of uveitis. It's an easy drug to use in that there's a very broad, safe dose range. So I've mentioned that I use up to 20 milligrams per kilogram. That's one of the advantages, is that we can really push the drug in patients in whom we don't get control. We worry about side effects. One of the important ones is exacerbation of or development of MS. We know that patients with intermediate uveitis are at higher risk of developing MS. So the recommendation is to obtain an MRI brain on any intermediate uveitis patient before starting TNF inhibitors, and obviously a neurologic review of systems on any patient before starting TNF inhibitors. We worry about susceptibility to infection, so we want a negative TB test before starting, and then we repeat the TB test every year. We worry about exacerbation of congestive heart failure, which is a problem more obviously in older patients. I have drug-induced lupus listed here, and until 2 weeks ago, I would have told you that I have never seen drug-induced lupus with infliximab. We see a lot of development of anti-double-stranded DNA. I stopped testing for it because it seems pretty irrelevant. But very recently, I did cause really impressive full-blown lupus with serositis, pericarditis, pleuritis in the wife of a physician whom I was treating with infliximab. So just remember that the risk of lupus is not insignificant. There's also, paradoxically, although we use this drug to treat patients with sarcoid, patients can develop sarcoid or a sarcoid-like reaction on infliximab. And I used to say, well, maybe we're just uncovering pre-existing disease, but in fact, this occurs in patients with non-sarcoid disease. Clearly, non-sarcoid disease can develop sarcoid-like reaction on infliximab. So I always have to show cases. I am a clinician. I am not a researcher. So this is a patient referred to me. He was a 29-year-old gentleman referred with oral ulcers and a diagnosis of panuveitis. He was on full-dose azathioprine and 20 milligrams a day of oral prednisone. You can see here, there's no clinical vasculitis, but you see a little patch of retinal infiltrate. This is very classic for Behçet's disease, but remember, this is also what we see with necrotizing herpetic retinitis. His workup for syphilis, sarcoid, and TB were negative, and he still had active cells. So one of the things I'm going to say is you can see there's no clinical vasculitis, but when we get a fluorescein angiogram, you can see that there is extensive vasculitis. And I'm putting in a plug for one of my talks tomorrow on the use of imaging in uveitis, because we can only see clinically large vessel vasculitis. You can't see small and medium-sized vessel vasculitis without a fluorescein. So you could see that he has extensive vasculitis despite being on an antimetabolite and oral prednisone. And here's what he looks like 4 months after we've started him on infliximab, 10 milligrams per kilogram every 4 weeks, which is where I usually start, and he's off oral prednisone at this point. So adalimumab, I've mentioned adalimumab already. It is approved in the United States and approved here, although not paid for. And this is approved for non-infectious intermediate posterior and panuveitis. So again, not anterior uveitis and not scleritis. This is a fully human agent. So we thought that we weren't going to get into trouble with antibodies against the drug, but in fact, we develop antibodies against adalimumab as well as infliximab. It's administered subcutaneously, as I said these biologics cannot be given orally, but these patients don't have to come into an infusion center. They administer the drug at home. The standard dose for adults is 40 milligrams every 2 weeks, and for children less than 30 kilograms, it's 20 milligrams every 2 weeks. So because I've said we develop antibodies, we use concurrent methotrexate or mycophenolate. There is really good data, again, for many forms of uveitis, and the side effects are similar to infliximab. This is actually my own data, full disclosure. It is, as I said, approved only at 40 milligrams per kilogram every 2 weeks, but we often have patients who fail that dose. So we looked retrospectively at 25 patients who had recalcitrant inflammation despite every 2 weeks adalimumab. I did this data collection before I routinely tested for antibodies, so I can't tell you which of these patients had antibodies and which didn't, but when we escalated to every week adalimumab, we had control of uveitis in over half of the patients. This has been a very useful paper. I don't know that anybody cites it in their publications, but this has actually become the most cited paper in uveitis sent to drug companies, to insurance companies. So this paper was done really to support insurance coverage of higher doses of adalimumab. So again, I'm going to show you a case. This is a 29-year-old woman who was referred with a diagnosis of acute retinal necrosis, not responding to antiviral therapy. She has decreased vision in both eyes. This developed 3 weeks after a C-section that was done for genital herpes non-responsive to valacyclovir. So she's referred to me from the retina service, and the retina fellow, when I asked, I said, so what about the review of systems? And he says the review of systems is completely negative. So here's her fundus picture. She has decreased vision in both eyes. There's anterior chamber cells in both eyes, vitreous cells in both eyes, peripheral retinal hemorrhages, there's vasculitis, and there's patches of retinitis. Again, you can see here, the patches of retinitis in ARN and Vachette's look very similar. So we decided to do a uveitis review of systems, which was a little different than the retina review of systems. The patient has sent me this picture. This is a lesion on her inner thigh. She gets recurrent oral ulcers, genital ulcers, and pustules on her skin, and what she describes as erythema nodosum. So I asked the retina fellow, well, how come your review of systems was negative? And he said, well, I said, are you healthy? So I'm going to tell you that are you healthy is not a review of systems. Because when she didn't have oral ulcers and genital ulcers and skin lesions everywhere, she was a marathon runner. So again, we need to specifically ask a review of systems. And it turns out that her herpes that was non-responsive to treatment, for which she had 3 cesarean sections, was actually Behçet's disease. So we diagnosed her with complete Behçet's, put her on oral prednisone, and I said earlier, I tried very early on to get biologics approved for Behçet's disease. They don't tend to respond very well to anti-metabolites. So we put her on adalimumab, 40 milligrams sub-Q every 2 weeks. The genital herpes went away, the oral ulcers went away, the retina responded beautifully. I tapered her off her prednisone. It's been 10 years, I still can't taper her adalimumab, and she still gets occasional breakthroughs that need oral prednisone. But this has been able to control her disease very well. So this woman presented 3 weeks postpartum. Can we use adalimumab in the postpartum period in someone who is breastfeeding? So I spent a bit of time looking this up when I prescribed this for her. So the answer that I got is it's probably safe for nursing mothers. In fact, I think it is safe for nursing mothers. It's a very large molecule. I don't think that a lot of it gets into breast milk, and then it doesn't cross the baby's gut, just like it doesn't cross the adult human's gut, which is why we have to give it parenterally. And then there's been a few cases where they measured infants' drug levels when their mothers were taking it while nursing, and there was undetectable levels in the baby's blood. So golimumab, this is fully human. The standard dosing is 40 milligrams sub-Q every 4 weeks, but we can go up to 100 milligrams. It can also be administered IV. The typical dose is 2 milligrams per kilogram every 8 weeks. I do go as high as 4 milligrams per kilogram every 4 weeks. Again, insurance coverage is difficult, though. There's a lot less data for this than other TNF inhibitors, and most of the data that we have is in patients who failed other TNF inhibitors. So So we're starting off with a population that is more at risk to not respond to drug. I'm going to talk a bit about tocilizumab, which I found very useful in my practice for retinal vasculitis. So this is an anti-IL-6 receptor monoclonal antibody. It is a chimera, so we do worry about anti-drug antibodies. The typical dose is 4 milligrams to 8 milligrams per kilogram IV every 2 to 4 weeks, and I have gone as high as 12 milligrams per kilogram. We can also give it subcutaneously, which is nice for patients who can't make it to infusion centers, and it's given at 162 milligrams in a preloaded syringe every week or two. Much of the data that we have on this is in JIA, uveitis, with macular edema or retinal vasculitis. And again, as with golimumab, this is typically used as a second or third line drug therapy, although I do have some comparison compared to infliximab as second line therapy. The side effects are a little different. In these patients, we need to monitor blood pressure, lipid profile, liver enzymes, and CBC. So the first published study on this was the Stop Uveitis study, looking at the safety and efficacy of tocilizumab in patients with non-infectious uveitis. They only published the 6-month data. There were 37 patients with non-infectious intermediate posterior panuveitis and randomized to 2 different doses of IV tocilizumab. And the primary outcome measure was actually supposed to be side effects. Secondary outcome measures were control of uveitis. So in terms of side effects, the drug was well tolerated. And in terms of efficacy, again, this is only 6-month data, but there was a mean reduction of central macular thickness of 60 microns, and there was no difference in eyes that were previously treated. And in terms of visual acuity increase, it was about 1-line improvement of visual acuity, although 30% of patients improved by 2 lines. And there was no difference between the 2 drug dosages, with the caveat that the study was not powered to detect a difference between these 2 dosages. It was a pretty small study. There's a larger data series that came out this year on anti-TNF versus tocilizumab in the treatment of refractory uveitic CME, and this is from the French Uveitis Network, and I think it's interesting that the French group, the abbreviation is FUN. So this was a multi-center retrospective observational study. These were patients with uveitic macular edema resistant to standard therapy. And they either got what I consider fairly low dose infliximab, 5 milligrams per kilogram every 4 to 6 weeks, or the standard dose of adalimumab, 40 milligrams every 2 weeks, or tocilizumab IV at pretty full dose, 8 mg per kg every 4 weeks, or subcutaneously every week. They defined complete response as the CME is gone and steroids less than 10 milligrams and no inflammation, and then various definitions of partial response. So overall response, 46% with TNF inhibitors and 59% with tocilizumab. Complete response, 22% with TNF inhibitors, and they found no difference between adalimumab and infliximab, and 36% complete response with toci, no difference between IV and sub-Q, which is a little different than what I see in my clinical practice. I do see better responses with IV than sub-Q. So I'm going to show you another case because again, I'm a clinician, and again, a plug to come to the talk on imaging in uveitis. So this is a 41-year-old woman who self-refers. She has intermediate uveitis. She's been managed for a couple of years by a retina practice, and she's treated with intermittent intraocular or periocular steroid injections every time she gets CME on OCT. But she says, even when they tell me I'm fine and my OCT is fine, my vision is terrible. She's an engineer and a really good historian. Workup was negative. Best corrected visual acuity is 20/20 in both eyes. She has vitreous cells in both eyes, no haze, and I'll show you here, no clinical vasculitis. So this is a very uninteresting looking fundus exam, but she tells me my vision is terrible. So we do an OCT, and you could see if you just look at these pictures, the right eye has no macular edema, but the left eye does have a little bit of CME. But here's another plug for something that's really easy to do. Look at the retinal thickness maps. So if you can't get a fluorescein angiogram that day, or if you're in an office that doesn't have the possibility of doing it, or if it's a kid or whatever late in the day. If you look at the retinal thickness maps, you'll see that this is not a normal exam in the right eye, and the left eye has more than just that little focal CME. And here is her fluorescein angiogram. Amazingly, she was followed by a retina practice for 2 years and did not get a fluorescein. So again, you could see that this is small vessel vasculitis. There's this ferning pattern of vasculitis, very, very characteristic of intermediate uveitis. But you saw, I also showed you this with a patient with Behçet's disease. So even though the fluorescein, even though the OCT looked normal in the right eye, there was a ton of vasculitis. So I put her on an antimetabolite, full dose of mycophenolate, and after 4 months, you can see that she actually looks worse because I haven't given her any periocular injections. So I said, okay, this isn't working, and I put her on adalimumab, and I swear this is not the same picture, just repeated. There's no response to adalimumab. But I've told you that in my hands, tocilizumab does work really well for retinal vasculitis, and here she is after 4 months of tocilizumab. So I have followed her now for 3 years. The fluorescein has been perfect, and I have just started tapering her tocilizumab the week before I got on the plane to come here. So we'll see how she does. So one of the things to think about that's coming is the advent of biosimilars. I understand that you haven't had to face this yet in Australia. This is something we're having to deal with in the United States. So one of the very important things to understand is that biosimilars are not generics. A generic is supposed to be, with the exception of hormones, absolutely identical to the parent compound. But biosimilars, as I've said, the biologics are made in a living organism, and these are patent protected. So the biosimilars are made potentially in a different cell, in different environments, different pH, so that they are similar to, but not identical to the original drugs. So it's similar in pharmacokinetics, it's similar in structure, but it doesn't have to be the same. And interestingly, in the United States at least, approval is based on what they call totality of evidence. And that means that they can actually be looking at data from the parent drug, not the biosimilar. And the drug studies do not have to be repeated with the biosimilar. So often these drugs are approved without data to show that they are effective. So I have no data on adalimumab biosimilars, but I'll give you a little bit of data on infliximab biosimilars. I tend not to use trade names in my talks, but because of the advent of biosimilars, I have to. So originator infliximab is Remicade, and there are a lot of biosimilars, ABDA, DYYB, I have no idea what all these things mean, but I'm going to give you some data on them. So there's really conflicting data. Data out of Cleveland Clinic last year showed that infliximab ABDA, or Renflexis, was associated with an increased risk of uveitis flares when patients were switched from originator Remicade. One study suggested that SB2 may have a higher rate of uveitis recurrence in comparison to other biosimilars. And again, no studies had to be done before these drugs were approved. So I looked at my own patients, 14 patients who were treated with Inflectra, which is infliximab DYYB. 7 patients were switched from Remicade to Inflectra for insurance reasons, and I was really, really surprised none of those patients flared. I started collecting data assuming the patients would flare. They did not. One was started for active arthritis and quiet uveitis. The uveitis did not flare. In 6 patients, we wanted to start infliximab, and they were started on Inflectra, not Remicade, and 5 of these patients, 5 of the 6, achieved disease quiescence during follow-up. I converted the dose of drug to a per week because some patients were on every 4 weeks, some patients on every 5 weeks, some patients on every 6 weeks, and the mean dose of originator that was required to control disease was the same as the dose of the biosimilar. So at least Inflectra, infliximab DYYB, does seem to be effective in controlling uveitis. But it's really important to remember that these biosimilars are not interchangeable. So you need to know what drug your patient is actually getting. Are they getting Remicade? Are they getting Inflectra? Are they getting infliximab? Renflexis. So if a patient is doing well and suddenly starts flaring, one of the things to do is check with the infusion center and see what they're actually getting. So What about dosing? I've mentioned already that we tend to need higher doses of biologics to treat uveitis than we do for rheumatologic disease. So it's important, if you're not the one who's actually treating the patient, please talk to the rheumatologist and explain to them that we need much higher doses to control uveitis, and there are a number of publications to support this. When a patient stops responding to therapy, one of the really important things we need to do is check for anti-drug antibody levels. And this is now very easily obtained commercially. Anti-infliximab antibodies and anti-adalimumab antibodies can be very easily tested, as well as drug levels. So if a patient has previously been responding and is now not doing well, I check their drug levels and the antibody levels. If the antibody levels are low, it's worth it to try doubling the dose or increasing the dose of the drug. But if they have really high antibody levels and really low drug levels, at this point, it's not worth trying to increase the dose, but we change the biologic. So this is often when we say, okay, TNF inhibitors aren't working, we're going to switch to tocilizumab. When do we taper or stop therapy? We're starting to collect better data. This is a very small study. This was a subset of patients from the Sycamore trial, which is a placebo-controlled trial looking at adalimumab versus placebo in patients with JIA uveitis non-responsive to methotrexate. This publication was on one center with 28 patients, and it's on a subset of 12 patients in whom adalimumab was stopped, and the majority of patients flared within 1 to 2 years after stopping adalimumab. The ADJUST trial is adalimumab in JIA, uveitis stopping trial, and this is looking at taking patients who've been quiet for at least 12 months on adalimumab and randomizing them to placebo, so stopping the drug or continuing the drug. And the outcomes will be looked at 6 and 12 months. I had to upload these slides yesterday, but actually as of today, there are 55 patients enrolled out of 118, and 3 of them were enrolled in Melbourne. Good job. None yet in Sydney. Get going. So we don't have data on this yet. In my practice, it depends on the disease and what is the risk of stopping. So if I'm looking at a patient with chronic anterior uveitis and cystoid macular edema, I'm okay trying to taper the drug and see what happens. I don't stop drug, I will taper it before I stop. So that's a little different than the ADJUST trial. But if I have a patient with foveal-threatening serpiginous or Behçet's disease with one retina left, I may never stop that drug. So I have a patient with foveal-threatening serpiginous in both eyes who knows that at least until I retire, he will be on adalimumab for the rest of his life. So there is a multi-center international trial now looking at tapering infliximab and tapering adalimumab. We have no data yet. We're just designing the trial. So I'm going to end on time with this very complicated slide on potential future topics for biologics. I promise I'm not going to go through the slide, just to say that there are a lot of potential treatment targets for uveitis. We're still waiting for the magic that works as well as a steroid with no side effects, and there's a lot of potential targets in the future. Thank you so much.
Thank you. That was a great presentation. We have got a couple of questions from the chat group. The first one is, do you still use infliximab or do you prefer adalimumab as your first choice?
Oh, that's a great question. So the question, if you didn't hear, do I prefer infliximab or adalimumab as a first choice? I would prefer infliximab in an ideal world because I can go anywhere from 5 milligrams per kilogram every 8 weeks to 20 mg per kg every 4 weeks. But because adalimumab is FDA approved, if I'm going to start a biologic, I will start with adalimumab, and then we switch to infliximab if adalimumab fails. But adalimumab, the dose is 40 milligrams per dose. We can't go more than 40 milligrams every week. I can't have the patient inject themselves every day. So there's just a lot broader dose range for infliximab. But I will start with adalimumab first. And adalimumab does have the advantage that the patient doesn't have to go to an infusion center. Infusions used to take about 4 hours. We now do rapid infusions, so it's only about an hour, but it still means the patient has to show up at an infusion center.
Do you have a theory at all about how drug-induced lupus occurs?
Oh, dear God, no.
Oh, okay.
I could make something up. I'm pretty good at making stuff up, but no.
Okay, no, that's all right. I think actually you've answered most of the other questions.
All right.
You did very well.
Well, thank you so much. It was a pleasure being here, and I hope to see some of you tomorrow.